Hello, we're glad you've joined us for this live webinar, Optimizing Antimicrobial Stewardship for Patients with Chronic Obstructive Pulmonary Disease within the VA Health System. I am Michelle Ashton of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by bioMérieux, a world leader in the field of in vitro diagnostics for more than 55 years. bioMérieux is present in 43 countries and serves more than 160 countries with the support of a large network of distributors. bioMérieux provides diagnostic solutions, systems, reagents, software, and services, which help determine the source of disease and contamination to improve patient health and ensure consumer safety. Its products are mainly used for diagnosing infectious diseases and some critical illnesses. The company's diagnostic solutions are also used for detecting microorganisms in agri-food, pharmaceutical, and cosmetic products. To learn more, please visit www.biomerieux-usa.com. Let's get started. You can pose questions to the speaker during the presentation. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click on the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of the presentation window. If you experience technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of the presentation window, or report your problem by typing it into the Ask a Question box located on the far left of your screen. This is an educational webinar and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Devendra Amin, Medical Director of Critical Care Services, Medical Surgical ICU, Neurocritical Care ICU at Morton Plant Hospital in Clearwater, Florida. To learn more about our speaker, please click on the Biography tab at the top of your screen. Dr. Amin, you may now begin your presentation.
Thank you very much for the introduction, Michelle. Thank you all for signing into it. I think it's a pretty important aspect of managing patients with COPD, which in your patient population is a significant proportion of the patients you deal with daily. Full disclosure, bioMérieux is sponsoring this presentation. And the objectives of the talk are to assess the burden of COPD and acute exacerbations, review the efficacy of highly multiplex respiratory panels, review the data on antibiotic stewardship with procalcitonin, and how they really impact in optimizing antibiotic exposure for acute exacerbations of COPD. I'll start with a case presentation. It's a 69-year-old male smoker, presents with coughing, congestion, shortness of breath, and a low-grade fever for about 10 days. Produces clear sputum. Historically, his wife and grandchild also had been sick with similar symptoms over the previous week. Here, the patient's past medical history, significant hypertension, coronary disease, congestive heart failure, diabetes, and obstructive sleep apnea. Not an atypical patient for the VA. Low-grade fever, 99.5, occasional basal crackles on auscultation, saturations are low at 90% on room air, and white count, non-specific. Initial procalcitonin was 0.2, that was at 5 a.m. in the morning. And then chest x-ray showed patchy bilateral airspace disease, as you can see. There's also some flattening of the diaphragm, suggestive of obstructive airways disease and some mild hyperinflation. So the question is, would you start antibiotics at this point, given the information that you have and the picture that you have? And then further information, the respiratory viral panel came back positive for human metapneumovirus by about 9 a.m. that day. And then the PCT came back on day 2 at 0.15 low, and then the next question would be, would you stop antibiotics given this information on day 2? At that point in time, sputum and blood cultures were negative and pending for the blood culture still. Just something to think about there. So we'll start with COPD and acute exacerbations. The acute respiratory tract infection produces high disease burden in adults and children. It's the third most common cause of death worldwide. And respiratory viruses account for 50 to 66% of respiratory tract infections, depending on the source of the literature. Rapid identification has the potential to reduce antibiotic exposure, initiate appropriate antiviral therapy when needed, and reducing hospital admissions, possibly reducing length of stay, and allows for appropriate infection control measures to take place. So going back, cigarette smoking was glamorized in the 40s, 50s, 60s, as you can see with these adverts for cigarettes as Christmas presents, supported by physicians historically, the cowboy lifestyle. But by the 1990s, things are beginning to change, and secondhand smoke and cigarette smoking in general is felt to be a bigger problem and probably not good. There's not just cigarettes, but also the burning of biomass fuels in closed environments also produces a similar syndrome, chronic obstructive pulmonary disease, in patients who don't smoke but are exposed to this kind of particulate pollution in closed spaces, and of course in open spaces with high particulate smog areas. The GOLD initiative for COPD came out in the late 1980s, and its primary function was to produce a non-biased review of the current evidence for assessment, diagnosis, and treatment of patients with COPD, and to highlight short-term and long-term treatment objectives organized into 2 groups, one in relieving and reducing the impact of symptoms, and secondarily to reduce the risk of adverse health events that may affect the patient in the future, to guide symptom assessment and health status management. So COPD is the 4th leading cause of death in the world, projected to become the 3rd leading cause by 2020, and more than 3 million people died of COPD in 2012, accounting for 6% of all deaths globally. The COPD burden is projected to increase in coming decades because of continued exposure to COPD risk factors, and aging of the population. It's a major public health problem, producing some 16.3 million office visits a year in the United States and about 672,000 hospitalizations. This is data from 2007. On average, more people die daily from COPD than diabetes or breast cancer, about 341 per day from COPD. So COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms, airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. The pathology and biopathology, as you can see there, smoking or pollution produces inflammation, impaired lung growth, accelerated decline in lung function, producing further lung injury, and there are systemic inflammatory consequences. Pathology occurs in the small airways, producing emphysematous changes, systemic effects, and then there's persistent airflow limitation, sometimes variable but more often fixed as the disease progresses, and the clinical manifestations are shortness of breath, made worse with exacerbations and with other comorbidities such as cardiovascular diseases. This is a diagram of how pulmonary function progresses over time. In the green line, normal people without COPD will see a slow decline of 1 to 2% per year in their FEV1. That's the forced expiratory volume in 1 second on a simple spirometry. In the red line, if you have a COPD history, a smoking history, you can see a fairly dramatic decline in lung function, FEV1, over a period of time. And then the yellow graph, the patients with small lungs but no COPD, you see a parallel in decline to the green line, but the black line would be small lungs with COPD, where you see an equally dramatic drop in FEV1 as time goes on. In general, if you stop smoking, it takes about 10 to 15 years to get back to the same rate of decline as if you had been a non-smoker. So it takes a long time for the effects of effects on lung function to go away, having stopped smoking. The most common respiratory symptoms include shortness of breath, cough, and/or sputum production, and these symptoms are often underreported by patients, especially shortness of breath, as they tend to reduce their activity level to compensate for their shortness of breath, so they'll often deny being short of breath, but a spouse will tell you that, or a partner will tell you that the patients are actually slowing down, maybe not doing as much, and when exerted, will get short of breath. The main risk factors, we've said, is tobacco smoking, but other environmental exposures such as biomass fuel exposure and air pollution contribute. There's a chronic inflammatory process developing, which then produces structural changes that produce the emphysema. The pathogenesis is from excessive oxidative stress. The protease, antiprotease imbalance develops, promoting more inflammatory cell promotion within the lungs, accumulation within the lungs and the tissue, with inflammatory mediators and peribronchiolar and interstitial fibrosis developing in the periphery of the lung. So looking at samples of, from washings of patients with non-smokers and during exacerbations, what you see is an increase in neutrophils as well as an increase in eosinophils. So it can be an inflammatory and/or infectious etiology, as you can see in patients with an acute exacerbation compared to baseline and compared to non-smokers. It's a multi-component disease producing a combination of mucociliary dysfunction. The mucociliary escalator stops working, mucus accumulates, producing structural changes. The inflammation that's developing around the airways, the small airways, produces airflow limitation. And there's a systemic component to the disease, including cachexia, loss of weight in a certain group of patients, classically the pink puffer type emphysematous patients, unlike the blue bloater, the large patient, often overweight, and but with significant metabolic abnormalities associated with this disease. So the diagnosis, key factors for considering a diagnosis: progressive symptoms over time, worse with exercise, symptoms are somewhat persistent, unlike asthma, they'll reverse to normal. There'll be a chronic cough, oftentimes with sputum, sometimes without, and recurrent episodes of wheezing from obstruction. Chronic sputum production can occur and suggestive of COPD, and propensity for recurrent lower respiratory tract infections as well. There are host factors, genetic factors as well, which are implicated, tobacco smoke, as we said, and from biomass fuels, and occupational exposure to dust, vapors, and fumes in industrial context as well. There's often a family history of COPD and or childhood factors with childhood exposure to smoke, which can actually, in pregnant females, can produce low birth weight childhood and respiratory infections and recurrent exposure as a child to smoke and tobacco pollution. This is a classic chest X-ray of a emphysematous patient. You can see the long lungs and see the very flattened diaphragms and the saber-sheath trachea shape and the barrel-shaped chest further down there. Simple spirometry is adequate for screening, and what you see here on the left-hand panel is the FEV1 being normal at about 4 liters. That's the forced expiratory volume in 1 second at 4 liters. The forced vital capacity, that's the total amount exhaled over 6 seconds at being 5 liters. And the ratio of the two is about 0.8, which is normal. On the right-hand side, you see the FEV1 reduced at 1.8 liters. The forced vital capacity over 6 seconds at 3.2 liters, certainly reduced from normal, but even more reduced is the ratio between FEV1 and FVC at 0.56, which is indicative of significant obstruction to airflow. If you look at the GOLD classification, in patients who have a reduced FEV1 and FVC of less than 0.7, if their FEV1 is greater than 80% of predicted, normal, but they still have mild COPD as that ratio is less than 0.7. If they have an FEV1 between 50% and 80%, they have moderate disease. Severe disease will be between 30 and 50% predicted, and very severe disease, GOLD 4, will be an FEV1 of less than 30% predicted. The differential diagnosis is significant. So not everybody who's short of breath and wheezing has COPD. So asthma, CHF, can produce what we call cardiac asthma symptoms or wheezing from congestion, bronchiectasis, tuberculosis, obstructive bronchiolitis, and diffuse bronchiolitis can all produce very similar symptoms and oftentimes minimal chest X-ray changes. So maintenance therapy and preventing exacerbations is key for good health and prolongation of maintaining pulmonary function testing in these patients. Of course, number one is cessation of smoking or exposure to the pollution. Correct inhaler technique is very important to teach the patients to use their inhalers correctly. Appropriate use of bronchodilators on a regular basis and PRN basis, depending on the severity of disease. Getting vaccinated, pneumococcal vaccine, and this time of year, the flu vaccine. Pulmonary rehab has been shown to improve functionality, not pulmonary function testing, but certainly functionality with appropriate pulmonary rehabilitation. And oxygen therapy in those patients who desaturate at night or with exertion is very important to help reduce the progression of disease. And in the very severe patients who have severe nocturnal desaturation and hypercarbia, retention of CO2, non-invasive positive pressure ventilation has been shown to improve outcomes. I'm not going to go through all the medications that are used in COPD now. There's been a large increase in the number of combinations, but certainly the basic medications remain the same. You've got short-acting bronchodilators, beta agonists, long-acting beta agonists, or LABAs. You've got the short-acting and long-acting antimuscarinics, LAMAs, and then you have the inhaled corticosteroids, long and short-acting, and a combination thereof. So baseline is treatment with short-acting bronchodilators such as albuterol for acute exacerbations. Maintenance therapy is long-acting beta agonists and antimuscarinics, anticholinergics, and then the use of inhaled steroids in patients who have exacerbations and to prevent exacerbation. As you can see, the inhaled corticosteroids, long-acting beta agonists, LAMAs, oral glucocorticoids for exacerbations, the PDE4 inhibitors such as roflumilast for very severe patients with end-stage disease, the use of antibiotics for prophylaxis. One major study, Alpert study, New England Journal, I think 2011, showed that daily use of azithromycin at 250 a day certainly reduced the incidence of exacerbations from, I believe, about 1.8 exacerbations a year down to 1.48, significant. It did improve the quality of life, but there was a cost to this with deafness and with patients who had QT interval prolongation. This was a problem. And the overall cost financially was about $1,000 a year. I think the study would have been better if they dosed this at maybe 3 times a week, because we know the levels accumulate and become very high with azithromycin, hence it's useful for short course treatments. That would have been a more appropriate study, not just for the anti-infective, but also for the anti-inflammatory effects of azithromycin in COPD patients. And lastly, there you see mucolytics and N-acetylcysteine and carbocysteine to help expectorate and clear that phlegm, which is often causing obstruction in the airways. So an exacerbation is a major problem that occurs and often causes a significant reduction in function in a stepwise fashion. With every exacerbation, patients have a decrease in their pulmonary function and capabilities, and they never get back to where they were. So an exacerbation is defined as an acute worsening of respiratory symptoms that result in additional therapy. In black there you see the classic Anthonyson criteria from 1987, and the type 1 exacerbation was defined by the presence of increased breathlessness, sputum volume and sputum appearance. Type 2 by the presence of 2 of these symptoms, and type 3 by the presence of 1 of these symptoms in addition to one of the following: upper respiratory tract infection in the past 5 days, fever without any other cause, increased wheezing or cough, or an increase in heart rate or respiratory rate by 20% compared to baseline. And that has stood the test of time. Exacerbations of COPD can be precipitated by several factors, again, cigarette smoke, pollution, infection, and the goal for treatment is to minimize the negative impact of current exacerbations and subsequent events. So early, rapid recognition of an exacerbation and intervention helps reduce morbidity. So there are host factors involved. Infection produces 50 to 70% of the exacerbations. And depending on the study, viruses produce between 20 and 40%. That percentage is going up over time as our ability to diagnose viral infections has become more accurate and complete with the respiratory viral panels that we'll get into. Bacteria is still implicated in about 50% of patients. And it's interesting, oftentimes these patients with COPD are colonized with bacteria, but it's not the colonizing bacteria that cause the exacerbations. There's usually a new strain that produces that, looking at recent research. Environmental factors play about 10%, and that is with sulfur dioxide, nitric oxides, nitrous oxides, and ozone producing significant burden on the lung when in high levels atmospherically. There's an increased inflammatory burden, an accelerated decline in function. The in-hospital mortality rate for acute exacerbation is between 8 and 11%, and the one-year mortality is 20 to 43%, I'm sorry, in one-year mortality in patients who've had an acute exacerbation in the previous year. So very significant implication there. In this study out of thorax, the European study looked at the distribution of causes of COPD, and some 30% were unknown, 25% were a combination of bacteria and viral, and then the rest, as you can see, broken down into bacteria and viruses. And similar proportions depending on where you are in the world, as we'll see. And again, you see the inflammatory changes there with eosinophils in some patients or neutrophils in others during acute exacerbation. So neutrophils tend to be higher in bacterial infection, eosinophils more in an inflammatory inflammation when precipitating an exacerbation. This study out of UK looked at C-reactive protein levels and microbial etiology in patients hospitalized with acute exacerbation of COPD. There's 264 patients with exacerbations of COPD, and 26% tested positive for respiratory viruses only, 13% had bacteria only, and 12% had mixed viral bacterial detection, and 49% had no pathogens detected. CRP level and temperature were strongly associated with viral detection rate, significantly, as you can see, which is different from other studies. So in here, you can see the mix of unknown viral, bacterial, mixed viral, bacterial on the left-hand side, and the breakdown on the right-hand side of various pathogens, mostly viral and some bacterial, as you can see. And then if you look at this panel looking at CRP levels, were very low in the bacteria and high in the virus only. And then if you looked at the temperature, also not very high in the bacteria, but high in the viral. You know, this is different from many other studies looking at this, which looked at bacteria as being a major cause of elevation in CRP. And this study, again, shows how the positive patients with CRP, influenza virus was very powerful in taking up the CRP levels compared to the lower panel, where the pneumonia patients with strep pneumonia, the levels were higher, but the percentage of patients were only about 6% of patients with a high CRP compared to the viral, which is up to 25% of patients. So in that particular study, the detection rate in respiratory viruses in hospitalized patients with acute exacerbation was strongly associated with host inflammatory response as measured by CRP and fever, reinforcing evidence of supporting that respiratory viruses initiate a large proportion of acute exacerbations, and that using this would help guide viral testing and direct antiviral therapy. Certainly the numbers show that a significant number of viruses are present, but whether CRP is helpful or not, it's unclear from this. This study out of Japan, more conventional, looking at pathogens and COPD exacerbations identified by real-time PCR plus older methods which included CRP. And interestingly here, viruses were only 20%, mixed was about 18%, bacteria only 48%, so slightly different mix there. But in this situation, what they saw was that the CRP group was significantly higher in the patients with bacterial infections and lower in the viral infections, so different from that previous study. The CRP is very nonspecific, can be up or down in viral infections, not very helpful in acute exacerbation of COPD in general. However, the benefits of real-time PCR identification suggested a higher number of patients were identified with viruses. So almost 90% of the patients had some diagnosis or some presence of a bacterium virus. So increased viral pathogen pickup from 20 to 32%, COPD exacerbations from gram-negative enteric or non-fermenting pathogens predicted long hospitalization, such as Pseudomonas, and CRP associated with bacterial etiology for acute exacerbations of COPD. This study looked at the effect of implementing the respiratory viral panel on antibiotic prescription patterns at discharge in adults admitted with mild to moderate acute exacerbations. This is a retrospective before and after study looking at the winter period from January to March between 2013 and 2016, and the primary outcome was antibiotic prescriptions at discharge. They enrolled some 232 patients, of which 133 following the RVP introduction, and the mean age was comparable in both groups. The patients in the pre-RVP group were similar to the post-RVP group for most characteristics. There was a significant reduction in antibiotic prescription rate at discharge in patients admitted with acute exacerbations after introduction of the RVP, or respiratory viral panel, 77% down to 63.2% with a p-value of 0.01. In adjusted analyses, patients in the pre-group with positive gram stains had a higher odds of having antibiotic prescriptions, even if they had a positive RVP. So again, clinical factors play a role here. Just because you have a positive RVP doesn't prove that you don't have a bacterial infection as well, so you have to look for both. So if the sputum was positive, they're more likely to have antibiotics prescribed, even if they had a positive RVP, which is appropriate. Here you can see the reduction in antibiotic prescriptions in the RVP-only group. Conclusion from that study was that in patients presenting with mild to moderate acute exacerbations, utilization of a comprehensive RVP panel can significantly decrease the rate of antibiotic prescription at discharge. There's a huge economic burden of non-influenza-related viral infections. It's the most common illness in humans. About 72% of surveyed patients had at least one episode in the previous year. Average of 2.5 episodes a year, most commonly rhinoviruses and enteroviruses, which produce about 500 million episodes a year nationally. Median duration was about 7.4 days, resulting in 20 million lost work days and 21 million lost school days. Increased burden and severity with asthma and COPD and patients with otitis media, and the annual cost was estimated in 2003 of being about 40 billion annually. A significant burden. This is a study looking at the distribution of pathogens in pneumonia patients. So even in pneumonia patients that initially were put into the study if they had infiltrates as well as signs and symptoms of pneumonia, and subsequently the results came back. Even there, the distribution is significantly higher for patients with viruses. The most common pathogens there were rhinovirus and influenza A and B. And then came strep pneumonia and other bacterial forms, and then other viruses further down. So just to emphasize, all infiltrates do not mean bacterial infection. They can be produced by a significant viral infection. So you have to be on the lookout for both types of pathogens in patients that are admitted with pulmonary infiltrates and respiratory symptoms suggestive of pneumonia or lower respiratory tract infection. This results in antibiotic misuse, inappropriate initiation, and prolonged use when you're always concerned there could be a bacteria, which is treatable compared to most viruses other than influenza, which are not treatable with specific antivirals, resulting in about 2 million illnesses and about 23,000 deaths a year in the US associated with inappropriate use of antibiotics. Quite significant. The problem with bacterial testing is the cultures can take 2 to 3 days to perform and get results back. They have a low sensitivity historically, and faster, more accurate indicators of infection are needed to make critical antibiotic decisions at the front end. As you've seen, about 50% of antibiotics prescribed for acute respiratory infections are probably unnecessary based on the etiology, half of the patients having viral infections. which causes a problem with misuse associated with drug toxicity, increased antibiotic resistance and collateral damage, increased drug resistance infections result in more serious illness or disability, higher death rate, prolonged time to recovery, oftentimes prolonged hospitalizations. We feel that if you have an antibiotic, it needs to be IV, has to be 7 or more days, which requires that much more hospitalization, oftentimes unnecessarily. And this is seen in the two most common syndromes of lower respiratory tract infection and in sepsis. We're used to using certain biomarkers for helping with identifying infections. Certainly in the pneumonia world, we're using strep pneumonia and Legionella urinary antigens. We're using the influenza enzyme-absorbed assays, immunoassays, and the polymerase chain reaction assays, which are now becoming more prevalent, more accurate, and multi-paneled. We use the MRSA PCR nasal swab, which has a low positive predictive value but a very high negative predictive value when you're concerned about an MRSA pneumonia or a healthcare-associated pneumonia. And then the multiplex panels, viral panels, allow for detection of a multitude of viruses with good accuracy and specificity and some bacterial targets, especially the atypicals. And those results can also come back very quickly in 1 to 2 hours, which has really helped improve identification and stratification of patients, either needing admission or appropriate antibiotic therapy or not. So this study, Brendish's study out of the UK, looked at using the multiplex respiratory point of care testing without antibiotic stewardship. So that's without a really major educational program coming into utilization of the testing. And surprisingly, not surprisingly, there was no difference in antibiotic initiation at the front end, but there were more patients with a short course of antibiotics of less than 48 hours in patients who had a positive point of care testing, 17% versus 9%, but the overall antibiotic utilization was still very high. But it did result in a decreased length of stay. There was a rapid identification of respiratory viruses, yields the opportunity for antibiotic avoidance. Reduction in unnecessary antibiotic use has not been consistently observed across studies, especially for adult patients when detecting viruses other than influenza. The main limitation of current respiratory molecular panels is the lack of bacterial targets for community or hospital-acquired pneumonia. There's always the thought of maybe they have a bacterial infection as well, or they're at risk for that. This study, Vos's study out of the Netherlands in Amsterdam, looked at it as a large study looking at the rapid molecular tests for influenza, respiratory syncytial virus, and other respiratory viruses. There's a systematic review of the diagnostic accuracy and the clinical impact of these studies. So they were either RSV alone, influenza and RSV, influenza alone, multiplex panels, using the diagnostic criteria, the Cochrane methodology for diagnostic test accuracy, and subsequently for impact on clinical care. We looked at some 4,200 studies and whittled it down to, for diagnostic testing accuracy, 56 studies that were felt to be appropriate to be included, and about 15 studies for impact of the studies. They felt that the accuracy was good, the pooled sensitivity of about 90.9%, pooled specificity of about 96.1% across all different testing. If you had a test that was specifically just for influenza that had a high accuracy, flu plus RSV test was also very high in accuracy. The multiplex BIOFIRE studies had a range of 89% and up, but 97.9% sensitivity specificity for the infections such as influenza and RSV. It also had the 4 bacterials or atypicals that were present on the panel. These studies tend to be more accurate in children as the viral load is higher. The other benefits are reduced turnaround time to less than 3 hours now, which results in a length of stay reduction and increased appropriate use of oseltamivir for influenza patients that are identified early. The clinical impact side, the 15 studies we said were felt to be appropriate for clinical impact, with 2 respiratory viral panel with PCT guideline studies there. Viral pathogen detection may not necessarily attribute causation, they felt. And the rapid molecular testing of viral pathogen detection provide accurate results. Clinical impact of rapid diagnostic tests was somewhat conflicting but there was a high quality evidence that rapid testing might decrease the length of hospital stay and might increase the appropriate use of oseltamivir for influenza. And they suggested considering implementation of rapid molecular tests within hospital settings and recommended performance of high quality randomized studies to confirm their results. This is the BioFire Respiratory Panel menu. It includes the common viruses that you see there, the most virulent being the influenza viruses and RSV, the parainfluenza, respiratory syncytial virus, and then the 4 bacteria on the right-hand side, Bordetella, parapertussis, pertussis, chlamydia, and mycoplasma. Under precautions, we've got a column there looking at different types of precautions that need to be taken at the bedside. A is airborne, mask and vented room if necessary. C is contact, hand washing, gloves and mask, and D is droplet. So if you don't know what the patient has, and they all have a relatively communicable disease, it's difficult to treat. And then you start getting staff getting infected, other patients getting infected. Of course, the most serious being influenza. But all the others do need some kind of isolation. So it's helpful to have that information. Certainly as a physician going from room to room, you don't want to catch even a common cold when you're on rounds. So it's kind of important to have that information. Also, it helps with discharging patients quickly if it's COPD with common cold versus COPD with influenza or RSV, which are significantly more severe disease. So the impact of early detection of respiratory viruses, this study looked at the impact of early detection of respiratory viral infections by a multiplex PCR assay on clinical outcomes in adult patients, comparing outcomes for adult patients with positive tests at a tertiary care center across 2 consecutive influenza seasons, 2010 to 11 and 11 to 12. Infections were diagnosed by conventional methods in the first season and by multiplex PCR in the second season. Viral cultures were done predominantly in the first season, and then there was the flu PCR available then. What they found was that FILMARRAY decreased the time to diagnosis of influenza compared to conventional methods, 1.7 versus 7.7 hours, p-value of 0.015, which is significant. And the FILMARRAY also decreased the time to diagnosis of non-influenza viruses, 1.5 versus 13.5, a very significant p-value, 0.0001. This clearly impacts patients in the emergency room that could be sent home rather than being hospitalized, and reduces length of stay and admissions. Admissions were reduced, length of stay was reduced, not so significantly, but still reduced, and duration of antimicrobial use was also reduced, as was the number of chest x-rays. So they concluded that with the rapid turnaround time, the multiplex nature of the test allowed simultaneous detection of array of viruses, and with the superior sensitivity of FILMARRAY may improve the evaluation and management of patients suspected of having respiratory viral infections. Next section, I'd like to cover the use of procalcitonin and then combining procalcitonin with a multiplex test to help fine-tune your management in these patients. So the VIDAS B assay helps guide appropriate antibiotic use. It's been available since 2007. It's an FDA Class II device. Has 2 previously cleared uses in the USA, 1 to aid in risk assessment for sepsis and septic shock on the first day of ICU admission, and secondly to determine the change in PCT level over time following ICU admission, which allows for prognostication. The PCT, procalcitonin, is a host response biomarker stimulated by bacterial infection. PC is a precursor of calcitonin and helps regulate the inflammatory response to bacterial infection. It is normally produced by many tissues, but only the parathyroid gland converts procalcitonin to calcitonin by the breakdown in the intracellular structures. The normal procalcitonin levels are less than 0.05. Bacterial infection stimulates PCT production in multiple organs outside of the parathyroid gland, and levels can go up significantly and can reach, it says up to 40, but our range in our lab goes up to 200. And if necessary, we can dilute that down further to get a higher level when necessary. So if you look at the chromatograph on the right-hand side, the thyroid cell being the highest producer for the parathyroids in that region, and all the other organs can produce procalcitonin in the setting of a severe bacterial infection. And PCT is produced by numerous organs, as you can see. It rises within about 3 to 6 hours. Half-life is 20 to 24 hours. and early identification helps in risk assessment. Elevated levels are highly suggestive of severe bacterial infection. As you can see here from this cartoon, inflammatory response from viruses, which are interleukin-1 beta and TNF-alpha, bacterial infections with interleukin TNF-alpha produce a significant increase in cytoplasmic mRNA, which increases the Golgi apparatus production of procalcitonin, which is then released into the circulation. If you have a viral infection, as you can see at the bottom, which is interferon gamma mediated, that produces no significant acceleration of PCT production, and so there's no elevation in a viral infection of procalcitonin. In the normal setting, in the parathyroid gland, the Golgi apparatus produces procalcitonin and it's cleaved intracellularly to produce calcitonin. But in the inflammatory state, when produced by bacterial infection, you see the uncleaved procalcitonin released into the cytoplasm. As you can see from this diagram, PCT levels go up significantly after the second hour following insult, up to pretty high levels, and then starts to come down predictably by 50% per day given the half-life, unless there's continued infection or inflammation where the levels stay high. But if you have adequate source control antibiotic intervention, the procalcitonin will start to come down fairly predictably. The other biomarkers there, interleukins go up with inflammation fairly quickly and also come down, and CRP is slow to rise and slow to come down. This is typical PCT kinetics, going up with acute inflammation infection, and then with appropriate antibiotic intervention or removal of the source, the PCT levels start coming down. And here you see another classic diagram of the PCT levels coming down with appropriate intervention and therapy. And usually you should see a good response in the first, probably at between day 2 and day 5, you should see a good response to appropriate therapy if it's working. PCT levels are significantly associated with severity of infection, with bacterial co-infection. In this study, looking at levels with patients presenting with a respiratory tract infection with a viral-only infection, no significant PCT elevation. With a bacterial co-infection, a significant elevation, suggesting there's a co-infection. Here we see PCT levels correlating with disease severity, where they present with simple and SIRS criteria. Sepsis, severe sepsis, septic shock is almost a linear increase in the range of PCT elevation. And then the other very important thing with PCT is this very strong negative predictive value. In these two studies, one confirming bacterial co-infection, second one need for antibiotics in a lower respiratory tract infection setting. If you have a negative procalcitonin, one less than 0.25, the need for antibiotics is significantly reduced at the negative predictive value of 92% and 94% respectively in these two studies. In those studies, when patients did not have an elevation of PCT, the need for antibiotics was not there. So it's a critical biomarker for bacterial infection, aids in assessing risk, offers specificity for bacterial infection versus inflammation alone, rises rapidly after bacterial insult, declines rapidly with control of infection, and has an excellent correlation with severity of illness. As we know, when patients present with an LRTI, clinical characteristics are not specific. Whether it's acute bronchitis, communicable pneumonia, acute exacerbation, the shortness of breath, cough, sputum, fever, oftentimes chills, aches, or pains, would tend to characterize more viral infection than bacterial, but there are other things in the history which can help, as in family history or not such family history, but exposure history to other people around you can help. The clinical characteristics are non-specific, and with this ambiguity, almost everybody got antibiotics, and as we've seen from the previous data, probably only 50% of patients presenting with these symptoms really need an antibiotic. So if the PCT on presentation is less than 0.1 or certainly less than 0.25, the need for antibiotics is discouraged or strongly discouraged if it's less than 0.1. In the setting of a respiratory tract infection, If the PCT level is above 0.25, 0.26 or above, we'd encourage it. If it's above 0.5, certainly strongly encourage use of antibiotics. This has to be taken in context with the clinical presentation of the patient. If it's a patient that looks septic but has a very low initial level, clearly you're going to give antibiotics. Same with community-acquired pneumonia presentation. But if its subsequent PCTs do not go up and stay less than 0.25, then you've got to think this isn't bacterial. Maybe we should be looking for something else and maybe not continue antibiotics based on the current data, as you'll see. And the other important thing is when do you stop antibiotics? Usually when it's back down to less than 0.25 or an 80% reduction from a peak is when it's safe to stop antibiotics, other than a couple of situations where we know that longer course antibiotics, such as with Pseudomonas or with MRSA, is indicated, regardless of the PCT level. So this study, Stolz's study, was a study looking at COPD patients in particular and the appropriate use of antibiotics, and following a protocol, as we saw with the 0.25 as a cutoff level, the appropriate use of antibiotics in the initiation and during the presentation of patients with an acute exacerbation of COPD. Some 208 patients were included, and the primary outcome was the antibiotic exposure at the index exacerbation and the subsequent antibiotic requirement for COPD exacerbations within 6 months. There's a 6-month follow-up on these patients. Secondary outcomes are clinical recovery, symptom scores, length of hospitalization, ICU stay, death, lung function, exacerbation rates, and time to next exacerbation. So the results showed that the index exacerbation, if you use PCT guidance for antibiotic utilization, there was a 40% versus 72% use of antibiotics based on the algorithm, and significant reduction in antibiotic exposure, relative reduction of 0.56. PCT guidance at the index exacerbation allowed for significant sustained reduction in total antibiotic exposure up to 6 months. Clinical outcomes and improvements in FEV1 at 14 days and 6 days did not differ between the two groups, and within 6 months, the exacerbation rate was about the same, rehospitalization rate was about the same, and time to next exacerbation was about the same. So reducing antibiotics by about 44%, and the absolute risk reduction by 31.5%, did not increase the rate of exacerbations or rehospitalizations. So that's significant. It is safe to do this using this algorithm. As you can see here, the actual reduction in the procalcitonin group was significant in the black bars. And then if you look at the amount of, the levels of procalcitonin were similar in both groups to help utilize this. And in the right-hand panel, you can see the exacerbations, no significant difference in the two groups, and the rehospitalization rate, no significant difference in the two groups over 6 months. The conclusion from that study was that PCT guidance for exacerbations of COPD offers a sustained advantage over standard therapy in reducing antibiotic use for up to 6 months with a number needed to treat of 3 without an increase in adverse events. They're pretty significant. Next, I'd like to look at this patient-level literature review and meta-analysis carried out in accordance with the Cochrane Collaboration Guidelines and the highest form of clinical evidence by actually utilizing data for individual studies and putting them together to get patient-level data, which produced greater statistical power and more robust findings than each individual study. There's some 990 records from the literature review, but 71 articles were assessed for eligibility after exclusion of about 919 records, looking at 6,700 patients for 26 eligible trials in 12 countries. The mortality rate at 30 days was significantly lower in PCT-guided patients than in control patients, 9% versus 10%. In the controls, the adjusted odds ratio of 0.83. The mortality benefit was similar across subgroups by settings and by type of infection. And the procalcitonin guidance also was associated with a 2.4-day reduction in antibiotic exposure, on average 5.7 versus 8.1, and a reduction in antibiotic-related side effects, 16% versus 22%. So the use of procalcitonin-guided antibiotic treatment in patients with acute respiratory infections reduces antibiotic exposure and side effects and improves survival. There's widespread implementation of procalcitonin protocols in patients with acute respiratory infections has the potential to improve antibiotic management with positive effects on clinical outcomes and on the current threat of increasing antibiotic multi-drug resistance. So when you review the data here, looking at baseline characteristics, effectiveness for initiation, effectiveness in antibiotic duration exposure, and the safety, there was a common theme. We're going to concentrate on the COPD patients, similar in both groups. The effectiveness for initiation, you can see in this graphic here, favoring PCT, that is reduced antibiotic exposure. And all these studies, including the STOLT study at the bottom, favoring PCT over control, for reduction in initiation of antibiotics or respiratory tract infection, significant reduction in antibiotic initiation there. And you can see study level findings for antibiotic initiation, NRTI, favoring PCT in all of these studies. And then the effectiveness for antibiotic duration and exposure, again, on the study level from 3 randomized controlled studies out of that number and data from 5 RCTs at the study level and the patient level. Again, a significant reduction in days at the bottom there, patient level 5 days versus 9 days. And in the study level, 7 days versus 10 days, favoring PCT. You can see here for acute bronchitis, there's a 65% reduction in antibiotic exposure in the PCT-guided patients versus control. And you can see for acute exacerbations of COPD, a 49% reduction in exposure if you follow the algorithm in the guideline. And looking at the safety, similar, no change in, no significant difference between in the control group versus the PCT group. If you look at this, similar rates of mortality in the LRTA patient level meta-analysis. Again, favoring PCT, complications of death, ICU admission, hospitalizations, respiratory infections, and recurrent or worsening infection. Again, similar lengths of stay, as you can see. And again, for the acute exacerbation of COPD, 30-day mortality actually was a little lower in the COPD group. So PCT can be added safely and effectively and used for 2 additional indications, which came out in February of 2017, which is to aid in decision-making in antibiotic therapy of patients with or suspected of lower confirmed respiratory tract infections, defined as community-acquired pneumonia, acute bronchitis, and acute exacerbation of COPD in an inpatient setting or emergency setting, and helped in aiding the decision-making on antibiotic discontinuation for patients with suspected or confirmed sepsis. So those are the 2 additional indications as of February 2017. This also helps you individualize patient care by measuring each patient's PCT and saying that this patient does or does not need antibiotics or it can be stopped at this point in time. That truly is personalized healthcare for the patient. And for each patient, inappropriate use of antibiotics exposes patients to the risk of antibiotic-associated infections and production of highly resistant infections. And for the healthcare system, there's an overall safety risk, as we saw earlier, with 2 million illnesses and 23,000 deaths from inappropriate antibiotic use. The PCT biomarkers can help guide effective treatment decisions, have been thoroughly studied in cases of suspected LRTI and sepsis, and associated with decreased antibiotic use without worsening clinical outcomes. It provides data needed to make more informed decisions on antibiotic utilization at the front end and at discontinuation, but it has to be used in context with clinical assessment and management of the patient as well. You have to take the whole picture into account, lab work as well as how the patient looks and other data that is available. And then finally, combining the highly complex or multiplex respiratory panels and PCT to optimize antibiotic stewardship in these patients with COPD. So this study looked at discontinuation rates associated with positive respiratory viral panel and low procalcitonin results improvement of suspected respiratory infections. Patients were required to have a respiratory panel or PCT within the first 72 hours of presentation. Drug orders were evaluated for discontinuation of antibiotic therapy within 48 hours of procalcitonin less than 0.25 and a positive viral respiratory panel result or both. Characteristics of the patients are similar in both groups, PCT and respiratory viral panel. The median length of stay in the PCT less than 0.25 was 4 days. For the positive respiratory viral panel was only 1 day. Antibodies prescribed, despite being a low PCT level, was about 70%, but in the positive RP panel alone was about 28%, so significant reduction if you had a positive viral panel. In the patients who had a positive PCT of less than 0.25 and a positive viral panel, for some reason, the antibiotic reduction was there, but not as much as with just the viral panel alone. It seemed that the positive or negative or low PCT seems to be ignored. This is a common theme. As you can see here, 71% antibiotics in the first 72 hours. Viral panel only 28%, and then 61% when you have both data elements available. So this is 4,869 patients with PCT and/or respiratory panel results. 2,031 were included. PCT and RP panel testing was obtained in 503 and 1,823 patients respectively, with 295 patients having both. Results of these tests suggested 789 patients were potential candidates for antibiotic avoidance, of which there were 219 with a PCT less than 0.25, 601 with a positive viral panel, and 31 with both. Antibiotics were administered to 307 patients in the first 72 hours, but discontinued at 48 hours of laboratory availability. These results suggest that the positive viral panel and low PCT results are infrequently associated with discontinuation of antibiotic therapy, improvement, or possible respiratory infections at our institution. Direct interventions of clinicians are likely needed to correct this behavior and decrease unnecessary antibiotic use. Again, this is when the test was put out there, but no real formal education going out. So it's very important when you implement a new test to have appropriate education and guidelines. And often a prompt in our institution, we had pharmacy calling up and saying that you have a positive viral panel, you have a negative PCT, consider discontinuing antibiotics if there's no other need to have them, like a urinary tract infection or something else going on. And over time, it took a few years, but over 3 to 4 years, the adherence to the guidelines has improved significantly. So we're seeing that being implemented more robustly now. But it didn't happen overnight. This study from Branch et al. Out of Rochester, again, looked at serum procalcitonin measurements and viral testing to help antibiotic use of respiratory infections in hospitalized patients. Randomized control trial, again, looking at the winter season, October through April 2014. Patients were assigned a 1-to-1 ratio to see standard of care versus PCT-guided care with the highly multiplexed PCR testing. Primary outcome was antibiotic exposure and safety assessed at 1 and 3 months. What they found was that there was a time-wise significant reduction in antibiotic exposure when there was a low PCT trend and the virus was positive. And you can see that the serum PCT levels are similar in both groups. So out of 151 patients in the intervention group, viruses were identified in 42% of patients and 83% of patients had PCT values less than 0.25. Again, there was no significant difference in antibiotic use or adverse events between the intervention patients and those in the non-intervention group. Subgroup analysis did, however, reveal fewer subjects with positive tests of viral infection and low PCT values who were discharged receiving antibiotics. So a lot more patients were started than probably needed to be at the front end, but there was a reduction in antibiotics at the time of discharge, which is encouraging. Shorter antibiotic durations among algorithm adherent interventions, 2 versus 4 days, compared with historical controls from the past 6 versus 4 days. So although antibiotic use was similar to arms, subgroup analysis of intervention patients suggests that physicians responded to viral and biomarker data, and this data could help design more future US studies. And again, key to implementation is education and then experience. And over time, doctors seem to agree that these tests are helpful and can help reduce antibiotic exposure. So to summarize, rapid diagnostic results are important. Getting the result back in a timely fashion within 2 or 3 hours really helps improve the adherence to protocols and guidelines. If you have to wait a day or two, antibiotics have already been started, and people are often reluctant to stop at that point in time. The negative predictive value of a low PCT combined with a strong positive predictive value of highly multiplex respiratory panel has the potential of reducing antibiotic exposure significantly. Results in less than 2 hours improves compliance. Real-time interventions improve results and reduces length of stay and reduces antibiotic cost. So that finishes the talk. We'll entertain some questions, and just like to review the questions and the answers to the question that we had at the beginning of the talk in terms of starting the antibiotic. I think most would agree to start the antibiotic given the data that they had, and then stopping at 48 to 72 hours once the results were back. We tend to stop antibiotics at this point in time with a positive viral panel negative PCT, but be interested to know how many patients would have continued antibiotics given that data. Thank you.